So moving on, we're going to talk a little bit about the use of mental health screening tools in primary care, and some of the tools that are available, and a little bit about management regarding the scores. Some references that are included with your information. The U.S. Preventative Services Task Force recommendations, as well as articles by Kroenke and Spitzer, who were involved in both the PHQ-9 and the GAD-7 tools. So this is, of course, not news to any of us in primary care, but it's estimated that 20 to 25% of general primary care patients have at least one underlying mental health condition. I'm sure most of you are thinking more than that, and that's true. The incidence is often twice that in uninsured or Medicaid populations. As we all know, depression and anxiety are amongst the most commonly encountered conditions. And of course, patients often do not come in and say, I'm depressed. They come in with headache, they come in with vague, and usually a list of vague complaints that it's hard to put together. And when using some of these tools can actually be amazing. Since my organization started using them, the number of patients that we've identified with having mental health problems has actually risen significantly. And oftentimes it's, I'm in here for conjunctivitis, and the next thing you know, they've got, serious mental health issues that never would have come up without screening. Of course, there is an issue with lack of mental health access, a shortage in the United States of mental health professionals. Primary care physicians are more than twice as likely to report difficulty in referring patients for mental health services than any other form of specialty care. Of course, that's dependent on your location, but it's particularly problematic in rural communities, and the southern states rank low in overall access to mental health care. This slide actually represents that well. I've actually highlighted those states that are represented by the Southern Medical Association, and you can kind of see how things fall out. So actually, I thought it might be interesting to kind of get an idea of where our participants were from. Do we have any District of Columbia? So you're actually in relatively good shape compared to a lot of us, and as one would expect, DC has services fairly frequently available. How are things where you're practicing? Mental health access is pretty good? None. And is that because of the population you serve?
It's just too many patients and not enough counselors, and none of the counselors take any kind of insurance or Medicaid, so therefore there's not accessible results unless in private pay. We do counseling, and then psychiatrists are so few that we can't get them.
So even though the resources are there, the patients can't access it.
Correct.
Okay. How about Maryland? Have we got anyone practicing in Maryland? No. Okay, so so as you can see, DC is 11 out of the 50 states plus the district. Maryland is 13, and then we jump all the way down to West Virginia at 34. Have we got anyone from West Virginia? Okay. Missouri, 36. Missouri. To Virginia, I'm from Virginia, and I thought this was interesting as I thought about it, and I'm sure this is true of other states. It's really actually hard to talk about access in the state because obviously with Virginia, the situation in Northern Virginia is going to be very different than what's happening in, say, Western Virginia and the Appalachians. Where I'm at, on the Eastern Shore, I'm on a 70-mile peninsula out in the middle of the water. We actually at the moment have one part-time, so 1.5 private adult psychiatrists, and one who will only see privately insured patients, and 1.5 in the Community Service Board who will see our uninsured Medicaid population, and then one part-time pediatric psychiatrist for a population of 50,000, which is actually considered good for some areas, but it is a challenge. Let's see here, Oklahoma. Anyone from Oklahoma? So Oklahoma ranks in there at 39. Louisiana at 41. We have someone from Louisiana. No? Okay. Florida? How about Arkansas? South Carolina. Must be some South Carolinians.
How about Kentucky?
How about Kentucky? Did I miss Kentucky? I did. I'm sorry. I apologize. How are things in Kentucky?
Not so good.
Not so good. Again, is the problem the number of specialists available, or is it an insurance issue?
Both.
Both.
Yeah.
Okay, back to our locals, our South Carolinians. How are things in South Carolina? Terrible. And again, is that an insurance issue or a number of providers issue? Both. Any Texans?
Of course, I'm from Texas. And in Texas, we don't do too badly. If you're in a big system, Dallas, Houston, around where we are, you have adequate psychiatry service because they're big, actually medical school systems. But if you're out in the rural areas, you can't even spell psychiatrist, let alone find one. So there you have it.
Georgia. Tell us about Georgia.
I'm in the Savannah area, and it's the same story. Not enough psychiatrists, and then the ones we have won't take insurance.
Okay, probably Savannah's, as a metropolitan area, is a little better than some of the more rural spots, I would think. Elsewhere in Georgia?
Most of our psychiatrists don't take insurance privately.
Okay. Tennessee.
I have two answers. Being in private practice for about 30 years, it was very complicated, and you never were sick enough. I'm now at the system called Charity Health, where we have behavioral psychiatry. And we serve only the underserved.
Okay. And that often seems to be the case if you're at either extreme. If you have, no insurance, like in Virginia, there's something called the GAD program, a Governor's Assistance Program, but you have to meet certain criteria. And actually, one of them has to be a documented mental health hospitalization in order, and that's a little bit of a quagmire because for so long everybody's goal was to keep people from being hospitalized, but now in order to qualify for this program, they have to have been hospitalized. And actually, where I'm at, there is no inpatient facility at all. You can't hospitalize someone. Let's see, Mississippi, Alabama. Tell us about Alabama.
We're always last except in football. But, I'm in Birmingham, so there are a lot of different mental health specialists in the city, but many have gone to the private pay, as already described, or limited, or only 40% or something like that locks a lot of people out. But I'm sure 40 miles outside of Birmingham is huge.
So again, I think all of our experience probably shows what the data shows, which is that primary care people are winding up doing the majority of mental health. So a lot of focus these days amongst the quality assurance kind of organizations. Patient-centered medical home, of course, for many organizations has replaced the old Joint Commission accreditation. And so they have set goals which include timely access to care, continuity of care, and coordinated comprehensive care, with an emphasis on not just doing those things, but being able to document and prove that those things are happening. NCQA, the National Committee for Quality Assurance, which is one of the PCMS accreditors, has developed levels in terms of accreditation for organizations. Both government and private health insurers plan to incentivize primary care systems to meet those requirements. So at the moment, NCQA PCMH Level 2 requires evidence of quality improvement efforts for 2 chronic medical conditions and at least 1 behavioral condition, in order to qualify for level 2 accreditation. And again, documentation is key. You need to be able to show that you're doing what you're doing. Electronic medical record systems do help with that. Many of them actually have built-in screening tools, such as the PHQ-9, PHQ-2, 9, and the GAD-7, and we're going to review those a little bit. The use of those tools actually creates searchable structured data. So whoever is submitting your organization's packet to NCQA to obtain accreditation actually has to be able to create a report that shows that patients are being screened and what's happening with that information. And so those can actually be generated from electronic medical records. There are also screening tools. Screening tools are available as smartphone apps, which clinicians can use, and actually some of them patients can use. Patients more often use them to monitor symptoms. Some people are very into that, and some of them can actually send them into clinicians' offices. There's actually a way to create emails and incorporate those into patients' charts as well. So the PHQ-2 or 9 is a depression rating screening scale that assesses symptoms over the preceding 2 weeks, and it's important that you focus on that when the patient's given it. It really is just looking at the last couple of weeks. The 2 is sort of the rapid tool, and it consists of just the first 2 questions of the longer tool. If either of those first 2 questions are answered yes affirmatively, then the longer version is administered. So this is what a PHQ-9 would look like on an electronic health record. These first 2 questions make up the 2, and as you can see, there's a scoring system that's not at all, several days of the week, more than half of the days of the week, or nearly every day. So the first 2 questions are, do you have little interest or pleasure in doing things? Do you feel really down, depressed, or hopeless? So if the answer to either of these is anything other than not at all, it reflexes to the longer version, which asks, do you have trouble falling or staying asleep or sleeping too much, either extreme? Are you feeling tired or having little energy? Again, extremes, poor appetite or overeating. Are you feeling bad about yourself or that you're a failure or that you've let yourself or your family down? Are you having trouble concentrating on things such as reading the newspaper, listening to the radio, watching television? Do you feel like you're moving slowly or do you feel like you're moving too quickly? Again, either extreme. And then thoughts that you'd be better off dead or hurting yourself in some way. Obviously, this question sort of is that would change your management immediately because essentially that's the patient that needs urgent care. So basically, at least in my organization, this is done by a nurse at intake. It's done once a year and updated on our charts. So that they actually print out the PHQ-2 and walk in the room with it. Technically, it's a self-administered tool. Some of our patients actually have a little difficulty with reading and writing, so in that case, the nurse actually reads the questions and helps them answer it. If they answer positively to each of the first 2, the 9 is then generated, answered, and then entered into the record. And it actually shows up on the HPI of that visit. So right under the HPI, there's a drop-down that says depression, lists their PHQ-2 or 9 scores. There's also this last question, which the counselors feel is probably, again, one of the more important ones, which is how difficult are these problems actually making your life? So are they giving you difficulty at work, being able to take care of things at home, or getting along with other people? So kind of like we had mentioned, the question with sexual dysfunction, if it's not necessarily a problem for the patient, then it's not necessarily a problem, but again, if they're answering a bunch of these positively, there's generally a problem. So the scoring comes out, if they score a 1 to 4, they're minimally depressed, 5 to 9, mild depression, 10 to 14, moderate, 15 to 19 moderately severe, 20 to 27 severe, but again, if that last question about harming themselves is positive, then obviously that would be considered severe and an emergency. So treatment selection and monitoring, if they're in that minimal to mild category, generally support. We would advise them to call their office if their symptoms worsen, and of course document that. And then follow them up again in a month to assess. And so, things are generally going to get better if they were situational. If something more significant is developing, then we could expect that we were going to be dealing with more of a moderate to severe depression. If for those people that are the moderate to moderately severe, options include psychotherapy or counseling and/or an antidepressant. In our practice, often they see the counselor first, and then she often will make recommendations. This patient seems like maybe you might want to consider an antidepressant if they're not already on one. We typically would follow up in a month, particularly if we started a medication, to make sure that they're taking it and that it's effective. And then if and when things appear stable, stretch that out to every 3 to 6 months. For severe depression, we typically start an antidepressant and refer them for both counseling and psychiatry, again, assuming that we can get them in. For us, the psychiatrists are more often going to be with the community service board. That's usually going to be a month or so until they can get what's called an intake appointment, which basically just gets them into the system, and then it could be several months until they actually see the psychiatrist. We typically, again, follow them up in a month or so to make sure that they're actually taking medication and that they've actually gotten an appointment, because a lot of times things do fall through the cracks. And then if actively suicidal, refer immediately to emergency services, which in my location essentially means the emergency room. There is another tool called the GAD, General Anxiety Screening, which is very similar to the PHQ questions. And this actually turns out to be important, as we've found out with administering the depression questions. A lot of times patients will say, well, I'm not depressed, I'm just stressed. And what they really mean is that their nerves are bothering them. And what they really mean is they've got anxiety. So the GAD-7 is a 7-question tool similar to the PHQ-9. It's scored 0 to 3 for each question, with a score of 5 being mild, 10 being moderate, and 15 being severe. This is a paper version of it. Questions are you feeling nervous, anxious, or on edge? Are you not able to stop or control worrying? Are you worrying too much about different things? Are you having trouble relaxing? Are you feeling so restless that you can't sit still? Are you becoming easily annoyed or irritated? Are you feeling afraid that something awful might happen? And again, scored as not at all, several days, over half the days, nearly every day, over the last few weeks. And if you've checked any of these problems, how difficult is that making your daily activities? There are electronic versions of this one as well as a smartphone app. So for the anxiety treatment and monitoring, it's similar to depression. For mild, support, call if the symptoms worsen, follow up in a month, see where we're at. For moderate, psychotherapy and/or an anxiolytic. We particularly try and avoid controlled medications, benzos, more likely to start with something like buspirone. Follow up monthly until the dosage is stable, and then every 3 to 6 months. Obviously, if severe, probably get them started on something to kind of try to stabilize while getting them into more formal therapy and psychiatry. And then again, see them back in a month, really just to confirm that things are in motion, but at that point the psychiatrist is probably managing medication. So ideally, what we would like is to have an integrated care model, and we're actually fortunate that we do have that in my organization. So we have integrated care is where a behavioral health specialist provides services within a primary care setting. We actually have a licensed professional counselor who's an employee of our local community service board, And we have 5 offices, and she actually goes to the middle 3, not the 2 extremes. Again, we're talking about 70-mile peninsula. So the middle 3 offices, she's Tuesday, Wednesday, Thursday, she's at one of each of those offices, and patients are referred from all 5 sites to her. She sees them for 1-hour visits. It's intended as short-term counseling. So essentially, if she can take care of the problem within 3 visits, then that's the extent of her intervention. For those that she determines need more long-term counseling or who need to see a psychiatrist, they are referred to the Eastern Shore Community Service Board, or in the rare cases where they've got insurance, to one of the private psychiatrists. So the U.S. Preventative Services Task Force has also picked up on this issue. In January, they updated the recommendations for depression screening. They recommend depression screening on all adults who are 18 years or older, and the most recent update includes screening all pregnant and postpartum women. They recommend use of the PHQ or similar tools, one of which is the Edinburgh postnatal depression screening, which is a 10-item scale. And again, this is a paper version of that scale, which asks similar questions to some of the others. First question is that I have felt happy, and the answers are all the time, most of the time, not very often, or not at all. And that's during the past week. And then during the past 7 days, I've been able to laugh and see the funny side of things. I've looked forward with enjoyment to things. I have blamed myself unnecessarily when things went wrong. I have been anxious or worried for no good reason. I've felt scared or panicky for no good reason. Things have been getting the best of me. I've been so unhappy that I've had difficulty sleeping, and sleep disturbance being a significant indicator. I felt sad or miserable. I've been so unhappy that I've been crying, and the thought of harming myself has occurred to me. So that's, again, scored on a scale of 0 to 3 with a maximum score of 30. There is an online version of this available. The paper version is scored a little differently. The electronic version is easier to use, but the paper version, options 1, 2, and 4 are scored 0 to 3 in descending order, but 3, 5 to 10 are scored in reverse order, and a score of 13 or higher is consistent with depression. Again, there are smartphone apps that will let you do these screening tools. They're available both Apple or Android and are free for download. Well, actually, one of them is the one that I'm talking about is MD Calc is available free for download. They give you the ability to evaluate and monitor symptoms over time, so they can be given at intervals to see if things are improving. MD Calc has the GAD-7 and the PHQ calculators with management guidelines and references. MedEquation is another one. That one actually there is a small charge for, and this one does have the Edinburgh as well as the PHQ-9. And I know we've talked a lot about apps. Apps can be really helpful, but also sometimes people can start to feel a little bit overwhelmed. This is actually a very nice site that reviews available medical apps and critiques them. Lets you search on a particular topic and also gives you some pros and cons. We're actually going to do some of that tomorrow. We've actually picked a number of smartphone apps that we're going to demonstrate. And again, we're going to review pros and cons, and we're going to go through some cases and let you see in real time how you would use them. I mean, actually, I would encourage anyone to, if you've got an app that you use on a regular basis, come and share that with us and we can talk about it. I got one yesterday from Dr. Hipshin that's on nausea and vomiting in pregnancy, which actually is a very nice tool that I'd never seen before. And Dr. Phillips demonstrated the contraception one, which was actually very nice, which we didn't include in our original list, but actually works well. So, we'd love for that to be a very interactive sharing session, and so please bring your tools with you. Okay, so now we're going to do some audience participation. And again, if you could point your phones or devices to this site, we'll go through these questions. Well, we're working on it. I'm going to go ahead. So our first question is, which of the following is true? 20 to 25% of U.S. primary care patients have one or more psychiatric conditions. U.S. primary care providers are twice as likely to report problems with mental health referrals as other specialty referrals. Mental health issues often present with somatic complaints, or all of the above. I think in order to get the real time, we need to go back, Randy.
Okay, you're going.
So, yeah, all of the above is obviously correct. So which of the following is true regarding the U.S. Preventative Services Task Force recommendation on screening in adults? The 2016 updates include a recommendation to screen pregnant and postpartum women. It states that the risk of potential serious fetal harm from antidepressants is small to moderate. Specifically recommends the use of PHQ-9 in all adult populations, or states that the optimal timing for screening intervals is currently unknown. The correct answer is A. They do not particularly recommend just the PHQ-9. It's one of many tools that can be used. Fetal harm is actually not considered a significant concern. Again, carefully choosing medications, and the optimal timing intervals are discussed, but currently there's, again, a big emphasis on prenatal and postpartum screening. Which of the following is not a recognized mental health screening tool? The SAD tool, PHQ-2, PHQ-9, GAD-7. SAD-2 sounds like it should be one, but actually I made that up. Number 4, which of the following is not true regarding the use of PHQ-2 and 9 screening tools? They are patient administered. They can be used for the screening and diagnosis of depression. They can be used to monitor effectiveness.
Sorry.
Studies have established that they are highly sensitive but not specific in diagnosing major depressive disorder. They are patient administered. That is how they were originally designed. They can be used for screening and diagnosis. They can be used to monitor treatment effectiveness. They can be given an interval, and you can document improvement. And they are both sensitive and specific. And then question 5, which of the following is true regarding the GAD-7 screening test? It can be used to diagnose or monitor depression or anxiety. It specifies that the questions refer to symptoms over the last 2 weeks only. It must be administered by a certified healthcare provider. Each item is scored on a scale of 1 to 7. So it actually is only used to monitor anxiety. The questions do refer to the last 2 weeks. Again, patient administered. Okay, questions?
I don't have a question. It's probably what a lot of us in the room are thinking. I think it would be great to administer these tests, but I don't know that I have the capability to do anything about them. And we have the problem in New Jersey that the postpartum depression, we have to screen everybody. It's required by law that we screen everybody for postpartum depression. And when we get somebody who screens positive, it's just an absolute panic in the office because we have nowhere to send them. We have no resources for it. And I just see this as such an important thing, but we're gonna fall into that same trap, is now I'm gonna become, you know, half of my, like I said yesterday, I feel like half of my practice is psych anyway, and I'm practicing psychiatry without a whole lot of background in it. So is there any suggestions for that? From anybody?
Our next speaker is in the back of the room.
Yeah, I think that's a very good thought, and we've had this kind of across primary care. We've heard this kind of, from various sectors, and not just primary care, but also kind of, medicine in general, as well as other specialties. To me, it's also about kind of trying to develop integrated care models. So what we've done is we have included psychiatrists within the OB clinics to be able to address some of that. So is there a way in which we can start to channel some of those patients who are difficult to treat within an OB setting to be able to kind of then be incorporated into psychiatry? Of course, we can't take all the patients, we're realizing that. So we have to kind of figure out a way in which to kind of, what's the right balance here? And we've done something very similar within our PCMHs too, patient-centered medical homes. So what we've done is psychiatry is clearly integrated within PCMH, OBGYN, we have integration within trauma surgery, because clearly there is the physical and the psychological trauma associated with those. We have one within senior primary care, within the geriatric medicine clinics, with the increase in the aging population. So we've made a deliberate attempt in terms of trying to make sure at least psychiatrists are available within these sectors. I don't know if that kind of addresses some of what you're talking about.
Right, and we had a speaker here last year from the Curlian Virginia Tech program, who actually is a double-boarded OBGYN psychiatrist, and she is embedded in their program. I know you at this point don't have one, but I think that a lot of places are looking to try and at least put a counselor or some access within offices, because it's true. I mean, basically, you're being told you not only have to do the screening, but you've got to document it, you've got to show you're doing it, and then you've also got to show what you've done for follow-through, and that a lot of times is where the real loop is.